host. My name is Nicolene Schiess. I'm an adult neurologist working in the brain health unit here at the WHO in Geneva, Switzerland. Neurocysticercosis refers to the development of T-solium cysts in the human nervous system. This can cause seizures, hydrocephalus, chronic headaches, focal deficits, and symptoms associated with increased intracranial pressure. As everyone knows, neurocysticercosis is one of the leading...
Bonjour.
Yes? Neurocysticercosis is one of the leading preventable causes of epilepsy worldwide, estimated to contribute to up to 30% of epilepsy cases in areas where the disease is endemic. This can also be much higher in specific communities. In addition to these new guidelines, which I am sharing today, the WHO is currently working on several other action areas to address the needs of neurocysticercosis. This includes the Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders, Ending the Neglect to Attain the Sustainable Development Goals, a roadmap for neglected tropical diseases, and mental health of people with neglected tropical diseases toward a person-centered approach. These guidelines were developed to assist healthcare providers in appropriate evidence-based management of parenchymal neurocysticercosis. The aim is to improve the decision-making, to ensure appropriate patient care, and avoid misdiagnoses and inappropriate treatment of patients with neurocysticercosis. The target audience is broad and includes healthcare providers working in first and second level facilities, policymakers, healthcare planners, and program managers, as well as academics and researchers in order to inform their teaching and research agendas. The methods for the development of these guidelines have been described previously in one of the earlier talks, and they were prepared in accordance with the latest standard WHO methods for guideline development. 9 PICO questions were developed to address a variety of different clinical presentations for people with neurocysticercosis. The first one pertains to the use of imaging and attempts to determine if the use of MRI as a first-line imaging technique is more accurate for diagnosis than CT scan. The following 6 PICO questions address various treatment options for people with different clinical presentations, including symptomatic neurocysticercosis with viable parenchymal brain cysts, single enhancing lesions, epilepsy, or calcified lesions. And finally, the last 2 PICO questions focus on the unique population of people who are living with HIV/AIDS and symptomatic neurocysticercosis with viable parenchymal cysts. Next, we are going to move forward with the recommendations. The first recommendation is involving the CT scan and MRI for neurocysticercosis diagnosis. MRI is the tool of choice in the diagnosis of neurocysticercosis, particularly when parenchymal viable parenchymal granuloma or neurocysticercosis of the cerebellum, brainstem, ventricular, subarachnoid, or spinal spaces are suspected. CT is the tool of choice for detecting small calcified lesions. It should be noted that CT can be used as an alternative where MRI is unavailable or contraindicated. The second 2 guidelines are for the treatment of neurocysticercosis with antihelminthic and anti-inflammatory therapy. Antihelminthic therapy, in combination with corticosteroids, should be given to individuals with symptomatic neurocysticercosis and viable parenchymal brain cysts for better outcomes in terms of cyst resolution and seizure control. Antihelminthic therapy with albendazole, in combination with corticosteroids, should be given to individuals with symptomatic neurocysticercosis and a single enhancing lesion for better outcome in terms of cyst resolution and seizure control. Recommendations 4 through 6 deal with the NCC-related epilepsy and anti-epileptic drugs. It is recommended that withdrawal of anti-epileptic drugs should be considered 6 months after the last seizure in individuals who have a single enhancing lesion and epilepsy with a low risk of seizure reoccurrence. Anti-epileptic therapy should be continued in people with a single enhancing lesion that continues to persist on neuroimaging, and those with a single enhancing lesion that resolves with residual calcification. Anti-epileptic therapy should be continued for at least 2 years in people with single or multiple calcified neurocysticercosis and epilepsy. These patients should be very closely monitored if treatment is withdrawn. The last recommendation is for the treatment of neurocysticercosis in patients with HIV and AIDS. Patients with neurocysticercosis who are co-infected with HIV should be treated according to the guidelines for treating neurocysticercosis without HIV/AIDS. In other words, these guidelines. In addition to the guidelines, we have included areas of research that is recommended to be focused on. The first one involves the diagnosis of parenchymal neurocysticercosis. It is recommended that programmatic research to increase the access of high-risk populations to neuroimaging facilities is recommended for the diagnosis of many neurological diseases, including neurocysticercosis. In areas where access to imaging is limited and costly, exploration of the use of serology as a first step in diagnosis is recommended. For the treatment of parenchymal neurocysticercosis, there are various areas on the research agenda that could be pursued. Randomized controlled trials of the optimal choice and duration for the administration of anti-epileptic drugs, definition of optimal combinations, dosing, and duration of anthelminthic and anti-inflammatory medications, determination of optimal anti-epileptic treatment and withdrawal of therapy for patients with calcified neurocysticercosis, and finally, determination of the optimal therapy and/or special considerations for people who are co-infected with neurocysticercosis and HIV. It was a great pleasure to go through these guidelines with you today.